Hello, good evening and welcome everyone to the eUROGEN colorectal webinar series. And this webinar is produced in collaboration with the eURN Ernica, the ARMNet and the European Pediatric Surgeons Association. And before we get started, I just want to take a couple of minutes to let you know what the eURNs do. eUROGEN is one of 24 European reference networks created by the European Commission in 2017, and the Commission kindly funds all of the eRNs. They cover most medical fields, and eUROGEN exists to provide highly specialised advice to other healthcare providers who are looking for advice on particularly difficult or complex or rare patients. So we're a network of 57 hospitals now, and one thing I did really want to highlight is we have a secure platform where we can give virtual advice via the network, the experts in our network, to any healthcare professional who wants it in the EU or EEA countries. So I really encourage anyone who's got a tricky case, please get in touch with us via our website, and we can arrange to use our secure tool and give you advice. So along with virtual consultations, we also have training and education activities like an eRN exchange program, this webinar series, and we also have a patient registry. And actually hospitals which aren't in our network can also join the registry. So again, please get in touch with us if you're interested. So this evening's webinar is about patients with trisomy 21 and anorectal malformations versus anorectal malformation patients without fistula. And it's a great honour to introduce our two presenters here this evening. We have Dr. Eva Amerstorfer, who is a consultant at the Department of Pediatric and Adolescent Surgery at the University Hospital of Graz in Austria, and Dr. Inbal Samuk, who's Director of Colorectal Service at the Pediatric and Adolescent Surgery Department of the Schneider Children's Medical Center in Israel. So ladies, thank you very much for sharing your expertise with us here this evening. And without further ado, Eva, I'll give you the floor. Thank you so much.
I hope you can hear me. Thank you very much, Michelle, and in the background, Lois and Darren. But I'd also like to thank eUROGEN for the invitation that Inbal and myself we allowed to talk about the issue of anorectal malformation in patients with trisomy 21, but also patients with anorectal malformations without fistula. They represent a very rare cohort of patients, and that was also the reason why that Inbal and we caught up this subject. In the ARMNet consortium, we are members from the steering group and have formed a working group on that, and would like to present you the data on it from the ARMNet consortium. Well, we try to start first with the anorectal malformation without fistula, and then continue with the special subject of trisomy 21 patients with anorectal malformations. Hope you like it, and I'd like to hand over to Inbal. Thank you for your attention.
Thank you, Eva, and thank you for Michelle for the kind introduction. Let me share my screen with you. And we have nothing to disclose. So this evening, I will talk about a distinct anomaly in the spectrum of anorectal malformations, the no fistula defect. This defect occurs in 5% of all ARMs. It has high association with trisomy 21. About half of the patients with no fistula also have trisomy 21. And when you have a patient with trisomy 21 who also have ARM, In about 90% of the cases, the type of the ARM will be the no fistula anomaly. In this defect, the rectum ends as a blind pouch with no communication to the urogenital tract or the perineum. The distance of the rectum from the perineum is variable, but is usually about 2 centimeters, and there is a common wall between the rectum and the urinary tract or the vagina. What about bowel control? So when we talk about bowel control, we use the term voluntary bowel movement. And this is defined as the feeling the urge to use the toilet to defecate, the capacity to verbalize it, and to hold the bowel movement. And in patients with anorectal malformations, this capacity is influenced by the quality of the sacrum, the quality of the spine, and the type of malformation. And in the subset of patients without fistula, most of them have a good sacrum, no tethered cord, and well-developed buttocks. And this is why the no fistula defect is considered an anomaly with good functional prognosis. And the fact that many of them have trisomy 21 does not seem to affect their prognosis for bowel control. This is in general, but looking at the literature, data are limited on the no fistula defect with or without trisomy 21. In this paper from 1998, they showed high rates of VBM both in trisomy 21 group and in the non-syndromic group. But in the next paper, the results were not as good. The rates of VBM decreased, especially in the trisomy 21 group. And in a more recent paper, the rates of VBM dropped to about 40%. And in this paper, trisomy 21 status did not impact outcome for VBM, soiling, or constipation. So indeed, data are conflicting. Considering that and the rarity of ARM without fistula, we conducted a study based on the ARMNet registry, and this study was presented at the UPSA last year in Tel Aviv. The ARMNet registry was analyzed for clinical and 1-year follow-up of patients without fistula born between 2006 and 2021. And currently only 1-year follow-up is documented in the registry. We do not have yet long-term outcomes. So we had 139 patients without fistula, which is 5.8% of all patients in the registry. We found a high male predominance, 76%, and this was statistically significant. 33% had trisomy 21, and 4% had other genetic variations. And this is the largest cohort of presented ARM patients without fistula. The most common associated malformations were cardiac, followed by renal, spinal, and tracheoesophageal. Only 4% of the patient had tethered cord. The sacrum was normal in 85% of the patient, where the sacral ratio was 0.7 or more, and only one patient had a poor sacrum, which is 0.4 or less. Colostomy was opened in 77%, and 20% underwent primary repair. Among the non-syndromic patients, 29% underwent repair without colostomy, compared to only 6% of patients with trisomy 21, and this was statistically significant. The type of reconstruction was PSARP or mini PSARP in 92%, lap-assisted repair in 4.7%, and anaplasty in 2 patients. 20% of the patients had post-op complications, the most common being wound dehiscence in 4.7%, stenosis or wound infection in 3% each, and rectal prolapse, and only 2 patients required a repair of the patient who had rectal prolapse. And the relative risk for complication was twofold more without stoma than with stoma, and this was statistically significant. On 1 year follow-up, more than half of the patient had constipation, and constipation was slightly more frequent in trisomy 21 group compared to the non-syndromic group. And also on 1 year follow-up, 23% of the patients had some degree of anal mucosal prolapse, but this required repair in only 2 patients. So in conclusion of this part, the ARM without fistula is a rare anomaly with a significant male predominance and high association with trisomy 21. Most patients underwent stage repair, and at 1 year follow-up, there was a tendency toward constipation and mucosal prolapse, and future studies are needed to evaluate long-term functional outcome. And with this, Eva now will continue with her talk on trisomy 21 and ARM.
So I'd like to continue now with the subject of trisomy 21 patients and anorectal malformations. And yeah, as you can see on the slide, and you all experience them yourself, they're very heartwarming, cheerful children and people in general, but are also rare in our group of patients, and they therefore really deserve our attention. So children with trisomy 21, they may have variants in the phenotypes of the extra chromosome 21. And the disorders, they can be either linked to craniofacial disorders, sensory disorders, for example, conductive sensory neural hearing loss, respiratory disorders like obstructive sleep apnea, autoimmune diseases like thyroid diseases or celiac diseases, but they all have a certain degree of neurodevelopmental disorder impaired, which is impaired, but also have to a high extent cardiovascular diseases, musculoskeletal diseases, and others. And I'd like to highlight a few of them, which are, for example, hypertonia, which all patients have to a certain degree. They may also have immune dysfunctions, for example, linked to parasitical infections. They may suffer from obesity from the very early childhood onwards. They have bowel dysfunction and gastrointestinal structural defects, as we know. They also may have autoimmune diseases like thyroid disease or celiac disease, also type 1 diabetes. And it's interesting that all these diseases may cause a disturbance in their behavior. And this is really something where we have to be alert that any behavioral change has maybe an underlying reason for it, which is linked to the variance in the diseases of patients with trisomy 21. So gastrointestinal disorders are in general very frequently observed. For example, constipation is there in about 20% of the patients. Obesity is observed up to 50%. Gastrointestinal reflux also about 50% in children with sleep apnea. Even Helicobacter pylori infections are diagnosed in about 75% of the patients who are institutionalized. Celiac disease is occurring with a percentage of about 6%. And like I said, gastrointestinal structural defects like duodenal atresia, up to 4%, Hirschsprung's disease up to 3%, and anorectal malformations. And so, of course, all these gastrointestinal disorders have an impact on bowel function, but bowel function is also influenced, for example, by hypothyroidism, also muscular hypotonia, or even eating disorders. And the remaining question is, what is actually the impact of anorectal malformation? Well, up to now, we really don't know. But as we've heard, Trisomy 21 patients, they have already a higher prevalence of anorectal malformations than in the general population. And we see, even though of this higher prevalence, we actually see patients with Trisomy 21 and an anorectal malformation very rarely. They have an incidence of about 2 to 5%, but as you've heard from Inbal, they have in 95% no fistula. And because of their rarity, patients with Trisomy 21 and anorectal malformation constitute an understudied subset of patients. And in fact, the data on long-term outcome of this cohort of patients is really scarce. And the literature, what Inbal was pointing out, for example, Torres, it's a very early group of patients from Professor Pena. He has included in his study in 1998 20 patients, and looking at the long-term functioning was even about 15 patients. And Andrea Bischoff has presented in 2014 a paper on 37 patients with Trisomy 21 and describing a long-term outcome in 18 patients. And the most recent paper from Sakar from Saudi Arabia, there are 9 patients were described. So in general, we cannot really conclude our known functional outcome from these patients, since they're really rarely presented in literature. And this was actually the aim to specifically also investigate the one-year outcome of patients with Trisomy 21 in the ARMNet registry, which is a European ARMNet registry, and obtained from data inserted by European pediatric surgical centers who are part of the ARMNet consortium. So coming to the results, the ARMNet database comprised 53 patients with Trisomy 21. There were 23 females and 30 males with a ratio of 1.1.3, and they eventually represented a percentage of 2.2% of all recorded cases, which were more than 2,300 patients. Looking at the arm type of all patients listed with Trisomy 21 in the ARMNet database, we saw that the majority, as expected, had an anorectal malformation without fistula. In fact, there were 83%, but we also had patients with a perineal fistula, which were 3, further 3 patients with rectal atresia, and 1 patient with a funnel anus. And in 2 patients, the classification of the anorectal malformation was not mentioned. In this patient cohort, congenital associated anomalies were recorded in 40 patients. And as again expected in Trisomy 21 patients, the most frequent defects are heart defects, followed by skeletal abnormalities and renal disorders like hydronephrosis or vesicular urethral reflux, and duodenal atresia, which was seen in 5 patients, spinal cord abnormalities in 2 patients. In fact, there was 1 patient with a syrinx and 1 patient with a tethered cord, and tracheal stenosis also in 1 patient. We had no patients with esophageal atresia. And looking at the skeletal abnormalities, we had only a small group of 18 patients where the sacral ratio was mentioned. And like the cohort from Inbal, most patients actually had a good normal sacral ratio above 7, and only 3 patients were listed with a sacral ratio between 0.5 to 0.65. So in almost all patients, the 87%, an enterostomy was opened, and 6 patients underwent a primary arm repair. In 1 patient, we did not have any information on the arm repair. So most patients were treated by a staged repair. When we look specifically at the enterostomies, we saw that most patients received a divided or split colostomy, which was in most patients also opened at the descending colon, and only 7 patients had a loop colostomy, also mostly opened at the descending colon. However, it was interesting to see that complications occurred in almost 50% of the patients with enterostomies. And in specific, we divided the complications into enterostomy opening complications. And there we had 1 patient with a stoma retraction who required a surgical re-intervention. All other patients or complications were actually treated conservatively or treated by the stoma closure later on. Looking at the enterostomy closure complications, we saw that these complications comprised like incisional hernia, an adhesion ileus, leakage or a fistula of the anastomosis, or wound infections. So all patients with wound infections were treated conservatively, but surgical re-interventions were needed in the patients with an adhesion ileus and, of course, fistula of the or leakage of the anastomosis. So in fact, 5 patients in total needed surgical re-interventions that were related to the enterostomy. And it was interesting to see that almost all complications occurred actually in patients where the stoma was opened as a divided stoma. Only the 1 patient with a loop stoma who had a leakage of the fistula later on required surgical re-intervention. Coming to the arm repair, the arm was corrected at a median age of 4 months in 49 of 53 patients. In 2 patients did not undergo arm repair. 1 patient died due to a cardiac failure. And in 1 patient, the anorectal malformation repair was refused by the patients. And in 2 more patients, we did not have any information on the arm repair. Eventually, the arm repair was conducted by PSARP in most patients. In 2 patients, it was assisted by laparotomy. There was no laparoscopically assisted repair of the anorectal malformation. The 1 patient with funnel anus was treated by an ASAP, and 1 patient with a perineal fistula treated by an anoplasty. Both these repairs were conducted primarily. So complications of the arm repair occurred in 16% of cases. In total, there were 8 patients, and 2 of them needed a surgical redo. 1 patient with a stenosis of the neoanus and 1 patient with a perineal dehiscence. And interestingly, the complications occurred in 2 from the 6 patients who were treated by primary repair, whereas 6 from 43 patients who were treated by a stage repair. So again, we have to say that complications occur with a 2-fold higher incidence in patients who are treated primarily compared to a stage repair. Looking at the 1-year follow-up, we had complete data of 34 out of 49 patients with an arm repair, which was about 70%. And in this patient cohort, mucosal prolapse again occurred with a percentage of about 20%, interesting all in staged arm repair. And this actually, the percentage is similar to the percentage what Inbal has presented. And looking at the constipation rate, we also saw that there is a high constipation rate of 59%. And the constipation is mainly treated by diet, laxatives or stool softeners or enemas, and only one patient required a disinfection of a fecaloma. And that's, again, as we said, the 1-year follow-up. So we have to say that mucosal prolapse and constipation are equally high in patients with anorectal malformations without fistula and with trisomy 21. So we don't really see a difference of patients with trisomy 21, that they have a certain impact due to their other, for example, gastrointestinal disorders on the 1-year outcome. But constipation and mucosal prolapse are frequently observed. So I'd like to conclude that 2% of patients with anorectal malformations have trisomy 21. And as we've heard, up to 95% of trisomy 21 patients have an anorectal malformation without fistula. In our cohort of patients, it was observed as 83%. A stage repair is associated with less complications, although we have to keep in mind that enterostomies itself have a high rate of complications as well in patients with trisomy 21. At 1-year outcome, constipation and mucosal prolapse are frequently observed. And I'd like now to hand over to Inbal to tell you the take-home messages.
So, on our take-home messages, we will repeat our some items that we have already concluded and talked about in these 2 presentations. So remember that ARM without a fistula is a rare anomaly, and there is a significant male predominance. It has a high association with trisomy 21, as we have seen and heard. It occurs in up to 95% of patients with trisomy 21. So again, when you have a patient with trisomy 21 who also has an ARM, in 90% of the cases, they will have the no fistula as a type of ARM. And at 1-year outcome, constipation and mucosal prolapse are frequently observed in all ARM patients without fistula, which calls for early management. And Eva, would you like to continue now?
Well, as I've presented, patients with trisomy 21, they deserve a multidisciplinary behavioral bowel treatment to obtain a good quality of life. Ideally, this may be conducted in a specialty clinic for patients with trisomy 21, but it should announce that patients with trisomy 21 have other congenital disorders, typically for their trisomy, and these have to be taken into account in the treatment. Well, what we still need are long-term studies on their outcome, because we cannot really give an answer what's their eventual impact of an anorectal malformation. And neither do we have this data really on patients with anorectal malformations without a fistula. And both these subjects are objective of further studies from the AMNET consortium. I'd like to end our webinar with a quote from the United Nations. Adequate access to healthcare, to early intervention programs, and to inclusive education, as well as appropriate research, are vital to the growth and development of the individual with Down syndrome. I'd like to thank the AMNET consortium for the support and the possibilities to conduct working groups and discuss several issues. And this picture is from the annual meeting in Graz from 2019, where Inbal has brought up the subject of anorectal malformations without fistula and trisomy 21 for the first time. So thank you very much, and I'd like to thank you for your attention, and I'm now opening for questions.
Yes, thank you both very much for a very nice presentation. Until now, I did not receive any questions, so please, for the audience, if you have any questions, type them in. In the meantime, would like to tell you that the webinar has been recorded and will be available on both our GoToWebinar platform and the YouTube channel, and the links will be sent later to you. All links for previous sessions are on our website, as are the details of the forthcoming webinars. You can also subscribe to our YouTube channel, where you can easily find past webinars. Finally, for all who have live attended today, you will receive a survey immediately after the session finished. And we would be very grateful if you could spend a few minutes filling it in to help us continuously improve further sessions. And what's new in 2023 is that you all will receive a certificate for attendance if you live attended the session. So let me see, we still have no questions. In that case, I think you had all a very clear presentation. If people from the audience do have questions, you can always, oh, there is one question, sorry. Thank you for this excellent presentation. My question is a bit off topic, but how do you look at the urological problem in your center? Question, what is your opinion on the surgical correction of undescended testicles in children with trisomy 21?
Do you want to relate, Eva, to the trisomy 21 question? And I will talk about the urological screening of ARMs.
To be honest, I would treat the patient with trisomy 21 as any other patient. And if there is an undescended testis, I would bring the testis down and fix it in the scrotum at the age of 1 year. It's part of the normal workup in every child, every male child, and of course also in children with anorectal malformations. Of course, they may have really a higher percentage of infertility later on, but if this is really linked to an undescended testis, I don't know. But I would definitely go for an orchidopexy at the age of 1 year. Don't know if he would behave differently, but I think not. Inbal?
We will do the orchiopexy the same age as we would do for another patients without a trisomy 21, as long as they don't have any issues that could preclude going under general anesthesia at the time. So with regard to the urological screening in ARM, it's really not so related to the topic of this talk. However, we have a working group on that issue because there is no well-designed protocol to follow on those patients with regard to urological malformations. We do know that there is a very high association of urological malformations with patients with the ARM, and usually the more complex complication, the more complex the anomaly, the ARM anomaly, the higher the associated urological complications. And also we know that even when the ultrasound as a newborn, the kidney ultrasound is normal, they may develop down the road associated problems. So we do recommend to follow patients even with low malformations with normal renal ultrasound after birth, to follow them closely also in the urological aspect. And I hope that with our working group on this issue, we will come up with a flow chart concerning this topic.
Thank you, Inbal. I forward one other question to you. I don't know if you can read it, otherwise I'll read it out loud.
I think we cannot read it.
You cannot see it again.
No.
Well, thank you very much for this presentation. I had one comment. I think that very long-term follow-up is needed to evaluate results in Down syndrome. Defecation is a complex process and needs particular intelligence. What do you think about that?
Well, I think it's, yeah, to be honest, it's a hard issue, a difficult issue, and we have to, as I presented, you have to look on different aspects which may influence defecation and bowel function. But on the other hand, it's maybe not the regimen. What we recommend is maybe not that easy and easy to handle in patients with trisomy 21. I think like laxatives or polyethylene glycol, it's probably the first start to treat constipation. But if it comes to like the transanal irrigations, they are maybe not that easily accepted by the patients. And I guess that the neurological impairment, which is existent to a certain degree, has an influence on that as well. But it's like a progress. You have to work closely with the patients and the families, and I think that's the goal to succeed.
Thank you. We have one more. Yeah, go ahead.
One more thing from personal experience. We have patients where transanal irrigations, for example, works, but it takes a while to introduce it.
And we have one more question from Leopoldi Tapia. He asks about complications of the enterostomies. Did you differentiate if they were more common in descendant colon or other enterostomies?
Yes, we also differentiated them, and actually most of the enterostomies were created and opened in the descending colon, and only 5 patients, I think as I recall now, were opened in the transverse colon, or maybe it were 6 patients. But in fact, more looking at the percentages of complications, they were actually more prevalent in the group of transverse colon enterostomies. So it seems that, of course, and we actually all know that treating patients with anorectal malformations, stomas should be opened at the descending colon, not only to avoid maybe complications, but especially to enable actually a high pressure colostogram, which maybe is difficult if it's opened in the transverse colon, and maybe they're as well affected with a higher percentage of colostomy, how do you say, a rupture, yeah, and or wrong results. And we also, me and Inbal, we discussed the issue about loop stoma or divided stoma, and obviously divided stomas had a higher percentage than compared to loop stomas. And I think that maybe it's the technical aspect that loop stomas are, but it's maybe only personal, and we still have to maybe evaluate that. But it could be that loop stomas are technically easier and maybe therefore also are less associated with infections or prolapse or stenosis. But
definitely a topic that should be further studied.
Exactly.
Great. Well, thank you both for your very interesting presentation, and thank you all at home for listening to us. And I want to wish you a very good evening.
And Louis, we would both like to thank you for the superb technical support.
You're very
Thank you very
welcome. Have a nice evening.
Good evening,
Bye.
everyone. Bye-bye.
Thank you, everyone. Bye-bye.